Okay, today we're going to talk about psychotic disorders. This is really the most serious of all mental disorders. So we're going to spend a little bit of time on this today. So there's several schizophrenic spectrum disorders. It's not just straight schizophrenia. And these involve psychosis most of the time. Except here, schizotypical, it's the personality disorder we talked about, and there's no psychosis. Schizoaffective is a mood disorder and symptoms of schizophrenia together, so they can have depression and schizophrenia together, or severe anxiety and symptoms of schizophrenia. Then there's schizophreniform. So this is like schizophrenia, but it only occurs for 6 months at a time. But later they can develop full-blown schizophrenia. Delusion disorders are under the spectrum. They have delusions, though, that can occur in real life. Instead of Satan talking to them, a delusion might be their husband is having an affair. And even though there's proof that that's not happening, they still will not believe it. But they're able to function, go to work, and go about their business. Brief psychotic disorder is with extreme stress. Somebody will become psychotic. And this can last anywhere from 1 day to 1 month, and then it goes away. And it is treated with antipsychotics at times. There's also some substance abuse-induced psychosis. And this could be somebody using LSD or some kind of hallucinogen, ecstasy, or any of the club drugs. And then medical problem-induced psychosis. There can be metabolic changes and neurological changes. When my son was in the 4th grade, he had a teacher who became psychotic because her diabetes was out of control, and she tipped over desks and she wouldn't let anybody out of the room. It was extremely distressing for my son. And this was related to metabolic changes of diabetes. Now, psychosis, NOS, means they don't meet any other criteria, not otherwise specified as NOS. And you'll see that a lot in medical charts and in psychiatric charts. They have psychosis, and the reason really hasn't been determined. So schizophrenia, this clinical picture, it is a chronic, very severe mental disorder that affects how one thinks, how they behave, and how they feel. 1% of all adults have schizophrenia. Males more than females, 4 to 1. They're not sure why. But the characteristic is psychosis for schizophrenia. They have altered cognition, which is thinking, perceiving the environment, testing reality. 75% develop gradually. Usually the age that people develop it is between 15 and 25 years of age. So some comorbidities that go along with schizophrenia: substance abuse disorder, especially nicotine, 70–90%. We used to have a smoking room on the mental health units, and the schizophrenia unit was the most packed, and they chain smoked during the whole smoking period. They stated it just made them feel better, and they haven't determined why schizophrenics get this relief of severe symptoms. They don't go away, but they're not as bothered by them when they smoke. Other things: severe anxiety or depression, and even suicidal thoughts because of having to live with schizophrenia and feeling helpless and hopeless. Some physical illnesses that go along with it: high blood pressure, cardiovascular disease, DM, diabetes, and COPD from all the smoking they do. And 20% have excessive thirst, polydipsia. So etiology, where does it come from? Well, biological. They say that if somebody in your family or your immediate family has 10% has it, you have a 10% higher risk of developing it yourself or that family member. Neurobiological, all the neurotransmitters are involved as well. um, brain structure abnormalities they found definitely have a significant role in this, and they can look at actual pictures of the brain and see some abnormalities. Psychological and environmental stressors, they think that maybe when somebody was pregnant, the prenatal stressors, having poor nutrition, some hypoxia, loss of oxygen, or viruses even when they were pregnant, could maybe put somebody at risk for this. Psychological stressors are when they're 14, 15, they could experience the development of schizophrenia due to some significant trauma or abuse or severe illness or stress. Sorry about that missing S. And then environmental toxins, they think, could possibly cause somebody to trigger developing it. Assessment. So during the prodromal phase, which is the phase before they actually develop schizophrenia, there can be some signs that people look for. And they look for some abnormal social development, some cognitive dysfunction, which means they're not thinking well, some reduced sleep and concentration. This is common to see when somebody goes away to college and say they're gone a few months and they come home for Christmas break. People notice that they're different. And it does happen going away from college. It's stressful for a lot of people. People are predisposed to it, often develop between 15 and 25, which are the college years. General assessment, they have positive symptoms, which means they have something that's not normally there with people without schizophrenia. Negative symptoms they also have, which is they lack something that people without schizophrenia have. Cognitive symptoms, changes in thinking, their memory, their attention span, all those things, as well as affective symptoms, which is their mood and affect. They may have some difficulties in this area. So in class, we're going to be doing activity. So when you come to class, I want you to be real familiar with the positive symptoms of schizophrenia, which we're going to talk about now. You're going to need to know these for our activity. So let's talk about the first alterations in thinking. They have delusions, which are false delusions, things not really going on, and they're fixed. No matter how people try and tell them that it's not happening, it's fixed. So magical thinking is part of this. They believe one's thoughts can affect another. For example, step on a crack, break somebody's back, they will avoid cracks. They believe in this magic. Or 13, stay in a room that's has or 13 anywhere on the wall that could cause a detriment to their health, well-being. Flight of ideas means they go really fast from one thought to the next. Even when somebody's speaking to them, they just keep going. Thought blocking means all of a sudden they're talking and they just abruptly stop thinking. And it's either they don't want to think about that or they don't want to tell the person they're talking to, and they just stop in the middle of talking. Thought insertion means that they think someone else is putting thoughts in their head, whether it be through a chip in their head or the government or the television. They have a lot of these things that happen. Thought deletion, they believe that somebody is taking something, some thoughts from their head. They used to know something and they don't know it anymore because someone stole it. Religiosity, they have a huge preoccupation with religion, with psychosis and the positive symptoms, especially Satan and God. You know, God might talk to them. Satan wants them to do bad things. And then they have cognitive retardation. Their thinking slows down a lot. And so when you're talking to them, they have delayed responses because their thinking is slow. They take longer than most people. Alterations in speech. Associations are the mental threads that tie our thoughts together. This is loose in schizophrenia, or they're interrupted. They lose some track of the mental threads. So one thing is clang associations you'll see. They like to talk in rhymes or sounds that are similar. They will use word salad. It's just a jumble of words without any connection. And down here in the bottom left, sometimes they'll write these out, and as you can see, it's a jumble of words with no connection whatsoever. Or neologisms. This is just made up words and word endings, and that's down here in the bottom right. None of these words make any sense. They'll make them up, and they'll make up what they mean as well. And echolalia, it's repeating exactly what somebody else is saying. If somebody's talking to them, they'll just repeat it. They say that this helps them ground them to reality by speaking that, like, okay, I hear them, this is what they said. Circumstantiality includes very unnecessary, tedious details in conversation. They may be describing something they did, and they will go on in very tiny, minute details. And then tangentiality, so it's going off on tangents for the main topic. You may be talking about a group in the day room, and they'll just go off on different topics. Oh, groups. I like groups. I like these kind of groups. And then they'll go and go on to groups and change those thoughts. So alterations in behavior. Now, catatonia is when they're laying in bed, usually or sitting, they're not talking, they're not moving. They're catatonic. Motor retardation is their movements are extremely slow, like they're moving in slow motion. Motor agitation, exact opposite. They're moving really fast. They have stereotypical behaviors, typical things that people think of when they think of schizophrenia. This picture below is waxy flexibility. So this means that somebody can put their leg in that position or their arm in that position, and they will maintain that position. So you turn their head a certain way, they will keep it there. Also on the top right there, echopraxia, different than echolalia in that they will copy whatever somebody does. Somebody folds their arms, they'll fold their arms. Somebody walks away, they'll walk away. And negativism, they think in negative terms about everything's going to have a bad outcome. They also have impaired impulse control. This is why you don't want to be close to somebody with schizophrenia until you know their level of functioning, because they're impulsive and they could grab something. They'll grab your badge, or grab something on you. Now, they also have this major boundary impairment. So they have something called depersonalization. They have these body parts where they're not sure that those parts are part of them. They'll stare at their feet and not realize they're part of them. They'll stare at their hands and not realize it. Also, they have derealization. They have the false perception that the environment's changed, that it's unfamiliar or strange. And why don't you go in the day room? That's not the day room. I haven't been in that room before. What is that room? And they're not sure. They really don't know. Alterations in perception. Hallucination, most common form of them with an inability to experience the correct sensory experience when there's no stimulus. For example, auditory hallucinations, very common. They hear voices. Visual, they see things that aren't really there. Olfactory, they might smell something like gas or smoke, and they can't believe when other people can't smell it. Gustatory, they might say, oh my gosh, I have this taste of blood in my mouth. What's wrong? Or taste of metal or something in their mouth. Tactile, they feel things on them. And then command hallucinations. Somebody tells them what to do. They may tell me, stand out here for 15 minutes and don't move. Or go to bed and lay on your back and stare at the ceiling. Or go over to that person and hit them. And they follow through and they don't know why, except that voice is commanding them. And then they also have illusions. Illusions are things that are real that they perceive incorrectly. And I think we talked about illusions before. And that's, for example, when they see something and they don't think it's what it is. They may see a car and think it's a UFO. And then negative symptoms. Now, there's other things that we have that they lack. So it's a different category. So anergia means they lack energy. Anhedonia means they lack pleasure. Avolition means they lack motivation. Alogia means they lack thought, spontaneous thought. And asociality, no social interaction. All those things that we have or somebody without schizophrenia have, they lack. So you can imagine for schizophrenia how difficult it is to function in society, to work. And their affect also. If you look at the picture of this gentleman, his affect is flat, no emotion. Sadness, depression, happiness, anger, nothing. Flat. That's what we call flat. Blunted is almost like flat, but they might have a little bit of emotion that you can see sometimes. And then inappropriate affect. They may laugh when something's not funny. And bizarre. So they may make faces sometimes. So they also have cognitive symptoms as well as positive and negative. So they have impaired attention. They can't focus for very long. They can't attend to something, to finish a task. Memory is terrible. For a lot of people, they can't remember people or places. They have trouble processing information. So when you try and do some teaching with them, it has to be done sometimes several times because they lack the ability. And then executive functions, which is planning, keeping track of a calendar, keeping track of where they have to be, paying their bills. They also lack concentration. They have trouble reading sometimes if they have these cognitive abnormalities. And problem solving. They need some help with problem solving. Affective symptoms. They are labile, which means they go from happy to sad, to bizarre, to blunted, to looking hopeless. And sometimes you'll see that flat affect when they're very hopeless. And then they experience dysphoria. So they're not satisfied with life. So what do you think the most important thing to assess with somebody with schizophrenia who has this labile affective symptom? Because of the hopeless and dysphoria, you need to make sure they're not suicidal. So some potential nursing diagnoses that you might use for somebody with schizophrenia or psychosis is, for the positive symptoms, you're going to look at disturbed sensory perceptions. You're going to look at risk of self-directed and other-directed violence because of their impulsiveness. You're going to look at impaired verbal communication. They have trouble because of their inability to focus, because of their psychomotor retardation and understanding. And then because of their negative symptoms, lack of motivation, etc., all those A's, which you should be familiar with that we talked about, social isolation and chronic low self-esteem. So planning. When they're in the acute phase, the focus is safety, of course, and medical stabilization. So deciding if they're inpatient, you know that's going to be, they're going to be at risk of harm for themselves or others. So they'll have a psychiatric, medical, and neurological evaluation to see if to rule out medical and neurological, they will do a CT scan and blood work and make sure it's not metabolic or neurological problems that are causing this psychosis. They'll do a drug screen to make sure it's not. Once they're determined that it's not, that it's psychiatric, they will start medication right away. It's the single most important thing to treat somebody with psychosis. So They need support. Evaluate if there's family support. Evaluate what their knowledge is. Are they new to psychosis? Otherwise, to educate them about them and help them guide through the process of recovering from this episode of psychosis. And they don't recover from schizophrenia. It is a lifelong struggle, a lifelong recovery to maintain the most independence they can. So they'll also need some supervision, definitely limit setting in the milieu, and that's the nurse's responsibility. Monitor their fluid intake. They can totally think they're being poisoned and they won't eat or drink anything. So phase 2, stabilization. Now that they're stable, you can do more teaching to help them understand the illness and the importance of their treatment, especially the medications. They have to be stabilized on the medications, and they have to be able to cope with their symptoms or control them in any way they can. And there are ways to do that, which we will discover soon. Making sure they're adhering to their medicines. Making sure they have relationship with the trusted care provider, making sure they're not somebody that they don't believe in that can help them. There are some community-based therapeutic services that will do home visits even to check on them, making sure teamwork, safety, the doctor, the nurse, the social worker, the therapist, the home health nurse, making sure they're all working together. And activities, keeping them busy, attending groups, group therapy, social interaction therapy, helping them promote social skills. And then phase 3, which is maintenance. Help them maintain achievement that they've made so far in being independent. Help them prevent relapse by using their coping skills, by taking their medicine, by using their support people, and then promote compliance with education again, helping them achieve the best level of independence to help them have a satisfactory quality of life using education. And the interventions for specific counseling and communication techniques to deal with their hallucinations, because sometimes they deal with them even with medication. So you need to see if they have any by watching for clues. Some clues are when I would be in a room doing an examination with somebody with hallucinations that were auditory, you could see them kind of tilt their head and cock their head, or they would mumble under their breath like they were responding, or they would look off into a corner or at the door. That would give me a clue that they were having some visual hallucinations. So watch for those clues and then ask them, are you seeing or hearing something that you're not sure is real? And don't treat it as real. Focus on reality. Well, I know you see some bugs on that wall over there, but it's not real. It's part of your illness. And then don't negate them. See, it must be very difficult to see things that aren't real, and offer empathy. Encourage distracting activities. If they're focused on hearing voices at the time or seeing things, let's go to group. Let's go in the day room and listen to some music. You can use the headphones. Simple projects. Why don't you focus on this project right here, an art project right now? It really helps them find what works for them. And then with their delusions, you have to be matter of fact. You have to show empathy to establish trust. Have to be calm and be supportive. Ask them to describe their delusion by using Tell Me More, which is a great therapeutic technique to use for them. Focus on reality. Observe them for triggers or themes. If they're always focused on spirituality, you may not want them to attend the mass because they become very impulsive and it feeds into it, and they become very loud in that group. And then avoid any kind of debates with them. That's not real. Yes, it is. I see it. No, it's not real. Avoid it. Say it once, but validate it if it is partially real. Those doctors down there, they're talking about me. You know what? I do see the doctors down the hall, and they are doctors, but they're not talking about you. They're having a conference among themselves about a specific issue. And that's things you can focus on. Now, interventions for associative looseness. Don't pretend to understand what they're talking about. Use I, not you statements, like you're talking too loud or you're talking too slow. Say, I can't keep up with your talking. Can you slow down, please? Or look for the recurring themes in what they're talking about if they're going on. And then ask them, tell me more about this thing. Try and summarize or paraphrase what they're saying if you can notice. Seems like you're really focused on that person in the day room. Can you tell me why? Or can you explain to me what it is? And health teaching. Talk to them about the causes of their illness, how important the meds are, what coping strategies they can develop, what they can expect as they're recovering, and then how to prevent relapse. So that's the end of this lecture. We're going to be talking about the medications in detail and the major side effects that these patients have to deal with. So we'll be discussing those in class and doing the activity we talked about the positive symptoms of schizophrenia. So please be familiar with those because it's kind of a quiz activity. And that's it for today. Have a great day.